Hello, thank you very much for inviting me here, and thank you for putting on this weather. It's much easier for an Australian to be here in weather like this. It's rather wonderful. So today I'm going to talk about a particular, I did exactly what the slide guys told me not to do and pressed the wrong button. How about that? So what I'm going to talk about today is about retraining approaches, particularly for the focal dystonias, which has been where I've been focusing my work on. But I did think I'd frame it a little bit, seeing the change in schedule happen, talking a bit about where focal dystonia treatment fits within the broad spectrum of dystonia treatments. And as you all know, you have plenty of definitions here. We know the generalized definition of dystonia, but the fact is that we know also that there's a lot of complicated variants and things that can happen in making dystonia express in various different forms. We have this maladaptive neuroplasticity, these brain changes that create sort of various dystonic patterning. And I will tell you from being at the conference, the other dystonia conference going on at the moment, there's an awful lot of exciting research into better understanding the disease. I think it's coming together in a promising way. I thought just to put me in perspective, when you look at all the different things that people are suggesting as treatments for dystonia, physio usually gets a little corner over here, so physiotherapy over here in dealing with the focal dystonias. It's happening a little bit more in some of the other dystonias as well, but this is where I'm going to focus on today, particularly in retraining, because as a physiotherapist, when I first had various focal hand dystonias and embouchure dystonias and things like this presenting to me, there was nothing available for me to work off, and I think this makes it difficult for everyone if we don't have some kind of treatment protocol. Just as a bit of a reminder, I know a lot of you will know this already, but when we're talking about these focal task-specific dystonias like musicians get, we're talking about aberrant patterns that happen usually during extremely trained movements and often quite well into their careers, so they're at the top of their game, international soloists, and suddenly things start going wrong and they're not sure why and can't control them, whether it's cramping, tremor, all sorts of things. In musicians, they say that dystonia is 100 times more common. This focal task-specific dystonia is more common than in other focal dystonia populations like golfers, yips, and things like this. It's also something that there's a lot of shame associated with. You'll find musicians panic if they even think they have it. They maybe just drop out, and we don't even know the full number of them. With the musicians one, things like the face pulling sideways when they try to blow onto an instrument, or the hand curling up when they try to play a guitar, or all these kind of things are fairly typical. It is an interesting condition that repetition plays into it, and various factors. In musicians, the very high incidence of focal dystonia, they think is partly also due to this perfectionistic kind of personality type that's fairly typical in musicians. So there's large numbers more than things like writer's cramp and golfer's yips and things, but a similar kind of presentation to me anyway when I see the different kinds of dystonia. This is the man I've been working with in the last few years, Professor Eckhard Altenmuller, particularly working with musicians' dystonia, although he is a movement disorder neurologist, sees other conditions. One thing I think is interesting that Eckhard has suggested is that perhaps when we look at dystonia, there might be a bit of a spectrum model, and so we're seeing people at different stages of this spectrum. And he also points out that many things may feed into it. So you can see there might be genetic factors. Often in musicians, there's a period of intense use that sort of ties into it. There can be all sorts of factors in their environment or psychological factors that also appear to be a trigger. And normally we can find these triggers when we're questioning people, which can sort of help us in making sure our management's targeted. So now, with Professor Altenmuller, we've got this retraining, really quite a good program up now where we will try to do retraining as the first step. If there's a lot of psychological factors, if that seems the prevalent thing, Eckhard is also a psychiatrist as well as a neurologist, so if it seems that is a very important thing to address first, we can also send that way. So if retraining doesn't seem to be progressing as planned, then we can go on to second stage, more medical kind of interventions that I'm sure other people will talk about. What retraining involves, so we have things like movement practice, which is along the lines of what I do, so trying to retrain movement. So this maladaptive plasticity, this kind of brain changes happen and you get dystonic movements. But it seems that we can, in a lot of cases, reverse some of this at least and retrain other movement patterns to become normal again in these focal dystonias. Sometimes constraint-induced therapy is used, so you use things like splints to try and keep the movements, the compensatory movements under control. And the idea is that then the dystonic movement doesn't have as much noise, there's not as much compensatory pulling away, so people can start to reforge a connection with it, so to speak. We always usually work on sensory retraining. It seems inevitable that things like your sense of feel of where your body part is in space and your sense of touch is always affected. So we will integrate this with our treatment in a lot of, I think all of us do this. You can use things like biofeedback, EMG. I've done this sometimes too to try and see whether that helps people to control the muscle activity. So this gives you a visual feedback of which muscles are firing too much and to see whether you can, if you like, see on a screen this amount of activity and change it by a particular behaviour. And some people do this, what we would call in sports actually, old way, new way. Like, can we teach you a new way to do it with some slightly different biomechanics that make a different neural pathway? I just thought I'd put this up because in a way the program that I developed is a little bit around an idea that's used in sport and even in musicians for when technique goes awry. Perhaps it's not a dystonic pattern, but you need to go through a period of working out what the chain of movement, what's going wrong along the chain of movement. So we have to really identify very clearly the main problems within the chain with focal dystonia. If I give an example of embouchure, you might see the face pulling sideways, but is this happening because the way the air is being supplied is not appropriate for what the face should be doing and they're having to work harder up here? This is a very simple example, but so we need to do this. With focal hand dystonia, often people develop quite a strong postural compensation around it, and we often have to go back and work through the whole chain. Once we analyse what is happening and bring the awareness to the person and, if you like, pull apart these movements and sort of identify the parts that we want to work on, there is often a stage where the performance will become affected. So by pulling it apart to rebuild it, there's a period where usually in musicians, for example, we'd say for 4 weeks, just don't play and don't keep reinforcing the patterning that we don't want to be reinforced. What we want to do is try and develop some more normal movement patterns. As you start to work on these, they become gradually more complicated. So I kind of call it an add-on approach where we have simple movements that become progressively more complex towards the task at hand, whether it's golf or writing or playing a musical instrument. And over then the final stages, this transitioning back to sport or music, it's a bit of a wobbly path. Some days work better than others, but once we get through a certain amount of this, it seems to go well. So I have quite a lot of people who've now been back playing for 10 years after dystonia and haven't had a regression. One thing that's interesting with retraining is you don't need, like with Botox, it wears off, botulinum toxin, it can wear off. With retraining, if you're building the pathway, it seems reasonably robust at the moment, but we need to do a bit more research. But what we do, have to work with a neurologist, make sure it is focal task-specific dystonia, nothing else. I strongly suggest this to, there's a lot of people perhaps not seeing expert enough movement disorder neurologists. So we make sure we analyse and record what's going on. And this is not just the movements, it's also a full medical history. And as I said before, whether psychological or genetic factors play a role. And then we start with restoring more simple movement control, gradually making the movements more complicated. So, we might start with a very simple task like trying to move a finger side to side. And then we eventually will sort of bring it into activities where this kind of movement happens during a more complicated task. So we bring those kind of movements back into a whole action. In anatomy terms, we sort of talk about this as just like using muscles in a prime movement, like the main action that they do, and then adding all the other muscles together in what we call synergies. So when you do things, groups of muscles work, not just a single muscle. And then we have to think a lot about these components, and gradually we need to withdraw how much you have to think about and get the thought process a little simplified so they can focus on the task at hand. I've put without stress there because when we go back to performance, whether it's orchestra or golf or anything like that, we do need to try and not go straight back to the most stressful thing. Musicians do this all the time. They go back to playing and put themselves in the hardest concert and the biggest gig, and this is just going to cause much more problems. So we try and graduate the return. So you've probably seen these sort of some of the groups of like what it looks like. I've got them all, a cacophony of sound here, so you can just sort of see all these movements, and there's obviously a lot of positioning. The guy, the drummer at the right, his arms sort of it's affecting right up to his neck. And you sort of see this kind of pattern fairly typically in dystonia. So one of the girls in the program with Eckhart, I'm just showing, so her little finger on the left side is curling up in a way she doesn't want it to as she's playing. And her index finger kind of lifts off to try and organise her ring finger. So you have this kind of compensatory lift here and curling and overextending through the finger. So she was having quite a lot of, obviously she was unable to play her repertoire, and she was completing a master's program in Hamburg. What we do, this is a very word-intensive slide, but it's just saying for particular movements like moving a finger, learning for a lot of people with the musician's focal hand dystonia, even to move a finger without moving a wrist is very difficult. So they'll do task learning to move a finger, move with the hand, roll with the hand. It's a little bit complicated to understand maybe unless you see this. So all I've asked this person to do is just move their arm back and forward and let their finger roll but keep it in position. And so he's having a lot of trouble not bending his wrist, not using the other fingers, like trying to do this in a smooth way. So often the tasks look quite simple, but of course they're extremely difficult with these kind of co-contractions in dystonia. But they're simple enough tasks. Sorry, I like these collapse at the end. He's like, oh my gosh, it shouldn't be that hard. But these tasks allow you to achieve and reach goals, like all these levels of it. You'll always be able to do some level of this that then you can build on and make it more complicated as you go along. So of our musicians, because of COVID, she had to send me the video, but she finished her master's, and I mean, it's sort of, like after 12 months, she's got pretty good control of it now, and it's got a lot better since, so she was very happy. She took this video for us because of COVID. She couldn't come in, so the lighting's a bit annoying. And I wrote up this protocol and published it, so people, if they're treating focal hand dystonia, have something to work with. It's an off-instrument thing. This was a really important thing, which is very against kind of current literature saying, you should do it on the instrument. But in fact, musicians find it quite traumatic. It's actually kinder to them to rebuild synergies off the instrument, and then we can take it back to the instrument, and they're feeling a lot more confident already and have some other strategies to use. So the next one I wanted to talk about is embouchure. Sorry, the girl on the right's talking for a while. So you can see with the flute, the cacophony here, sorry about this. So the guy down the bottom has a lot of tremor and twitching as he's doing it. The flute player, it's moving to the left. The other one I didn't edit it very well, so it takes a little while into it. But what I wanted to show is there's so many things going on. They're really describing all the complexities they're having, even if it's not so obvious from the start. So here's one of our embouchure retraining people. And he'd just got a big job, and his embouchure just disappeared on him. So this is it's traditionally been quite a difficult problem to treat, and part of the reason is the anatomy of this area is complicated and all the functional things coming together, like in many tasks, are relatively complex. They don't learn anything about how their face muscles work, how they breathe, like musicians who, I don't know if there's many musicians in the audience, but wind and brass players literally just don't know about how this apparatus works. So if something goes wrong like this, they're extremely disempowered to do anything about it. So with the retraining program here, followed a similar idea, right? So make simple movements, try and check symmetry, and we have to work, like check the breathing and the posture and the tongue and the throat. And like we sort of have to check through the train of things and sort of identify what things are working well, what things are working not so well. Usually I think it's always good to have some tasks to do that are relatively straightforward. So often a compensatory thing might be you lean forward and bend to blow on the instrument. It's a bit like focal hand dystonia. You'll tend to sit away from the affected side, and this can be also problematic for you to recover. So trying to address these relatively easier wins and then work on building up the muscle complexity. With the series, this is like an example of just very fundamental movements that we then add on, like so make the muscles work together with breathing, with resistance, things that more mimic what you do on the instrument. So this was like, actually this guy was interesting. So when he came in, he was a bit distressed with his early trumpet playing, and he tried playing tuba for a while. He thought he might just toss it in and try doing tuba, but then came back, and so I've asterisked 12 months because I'd shown him exercises, but he kind of took 6 months mucking around with the tuba and then came back to it. So it's possibly a bit less than 12 months, and so he's just... Kind of a nice triumphant way to finish the talk. And these guys are actually still improving. So one of the interesting things with people who do well with this program is that they seem to be able to continue then to make their own gains, work on things, apply things musically. I think it empowers them to understand how the system works, and it's a complicated process. They work very hard to kind of get it better, but then they're still keep progressing, which is a nice thing. So I hope that we can find more and more about pathways like this that seem successful for certain people. For some of the people, we did mixed methods, like it worked well to combine it maybe with more severe cramps with some botulinum toxin in some cases. Some other people, a bit of medication, but all of them did the retraining. And as I said, it just seems to make, for example, with the botulinum toxin, it seems to make the necessity for your next injection greatly stretch out and reduce. So that was also encouraging. So, but we do need to do a lot more study. It's just, it's looking very positive for a certain subgroup of people. And, the more we learn about ways to retraining people who we can retrain out of dystonia, the better. But I think I just put this quote in from one of the players, just because these exercises are very much the same as what I would do with golfers, yips, or some of the dressage, hand cramps and rider's cramp and things. Very similar exercises because they're off instrument, and then we just have some special ones to transition them back on. But the lack of anxiety, emotional trauma, anxiety when you take it off the instrument can be a nice place to start. So thank you very much, and yes, I'll leave it back over to...
Thank you, Maria, and thank you everyone for coming today. I'd just like to say thanks to Dystonia Ireland, to Dystonia Europe. It's a great opportunity to be able to meet people and talk to people and have this kind of informal but formal discussion where we can start talking about what's going on. I've chatted to a couple of people in the audience already, and I get the sense that there's a great need for this kind of a forum, so thank you for organising it, everyone. There's a slight change to the schedule today due to illness, so actually our last speaker on the schedule is actually now going to be our first speaker. So I might just start by introducing Professor Bronwen Ackerman. So Bronwen's a Professor of Anatomy and Physiotherapy at the Faculty of Medicine and Health at the University of Sydney. She's a specialist in musicians physiotherapists and has worked clinically treating musicians' performance-related health issues, including dystonia, for about 30 years now. Recently, she completed a Humboldt Fellowship in Germany with the neurologist Professor Eckhard Altemüller, and she's conducting research into developing standardized protocols for retraining for both focal hand dystonia, as well as a particular type of musician's dystonia, which she's going to talk about today. So it's a very interesting talk that I'm looking forward to. So I'd like to welcome Professor Ackerman. Thank you.
Oh, sorry, does anyone have any questions? Yes, Connor's pointing out, I didn't know if we had time.
Just in case there's any questions in the audience. I suspect that there's a roving microphone in case anyone would like to ask a question. I might just start. So, fascinating talk. I'd say there's a lot of people in the audience who say, well, I don't play the trumpet, I don't play the guitar. So I have two questions. One is how translatable do you think these techniques are to more common forms of dystonia? Even we talked about simple focal hand dystonia, but then cervical dystonia or other dystonias. And the second question is, how available is this worldwide, and how difficult it is to have these skills really trained up in somewhere like Ireland, for example?
So in relation to the first question, I think it's really an interesting possibility that I think we need to explore more. I think from a physiotherapy perspective, we haven't been in perhaps the rehabilitation conversation as much as we could be. I think there is interesting potential, and hopefully it goes further. With the availability, I'm publishing these protocols because I want it to be available and I want more people to perhaps make them better, improve on them. When I started, there's just nothing there. I didn't know what to do. And it really was a long time of doing it where you think, oh, I think I've got a pattern that's working quite well. So I throw up this as if it's simple, but it was like really 20 years of stubbornly trying to fix these problems with the embouchure dystonia, for example. So one of the Toronto Symphony Orchestra musicians who's back playing and one of the Boston Symphony Orchestra musicians who's back playing have started this whole embouchure consortium now where they're trying to make this information accessible worldwide. But it is, sorry, you're passing around.
Sorry. Here you go. Thank you very much for all you told us. It was very interesting. My question is, I believe I was born with this dystonia. Mm-hmm. Would that be correct? I was always very clumsy as a child.
Yeah, absolutely. So one of the complexities with dystonia is there's many, it's a very big disorder. We're understanding more and more about it, but some people are born with it. We don't really fully have the answers to all this evolution. I think you'll hear more about this from some of our other speakers today, but some people are. Other people, like some of the musicians, there's families that seem to all develop it. So there's definitely various elements, yes.
We might cover that in some of the later talks actually as well, so it's a very good question. Any other questions for Professor Ackerman? There's one over there, I think.
Hi, thank you for the talk. When there's a patient who may have a surgical need, is there anything in your protocols that might guide the pathway that patient may follow? Should the surgery take place first, or should the physical therapy happen beforehand, or should it happen as part of a multidisciplinary input or team?
I think almost in an answer to your question, possibly all three. Like, we're trying to make these trials bigger so we can work out this timing. I think as a physiotherapist, I'd say, look, I would try the conservative option first with some of the people, for example, who did conservative, even with adding Botox later because they had quite severe cramping. It actually really helped that they'd tried the exercises first, then had reduced some of the co-contraction, and then were able to do it. But the possibilities with it in a case even where you need surgery, usually we would do a little bit of retraining prior to surgery, even if it's difficult, just so you understand it, we see how well it works. Then after surgery, it's often much easier for you to do these kind of exercises. But I think it has a lot of potential. We just need to do a lot more research.